Hey, good morning, everyone. My name is Denard Cummings. I am the Director of the Bureau of Social Determinants of Health. Before we get started, I wanted to share a few housekeeping items. Today's webinar will be recorded. The recording and slides from today will be posted on the Social Determinants of Health website. During the webinar, all lines will be muted. Please use the Q&A box to submit burning questions. Time permitting, we will address as many questions at the end of the webinar as possible. A formal Q&A document will be posted on the SDH website once all questions and answers have been compiled. At the close of today's webinar, there will be a survey link provided. Please take a moment to complete the survey to help plan future webinars. As mentioned earlier, my name is Denard Cummings. I'm Director of the Bureau of Social Determinants of Health. Today, I am joined by Martina Ahadzi, Emily Engel, and Ryan Ash. The goal of today's webinar is to share the VBP requirements, clarify the state's intentions regarding community-based organizations and the role they will play in addressing social determinants of health in New York State. The Bureau of Social Determinants of Health was established in December of 2018. Prior to that, we were the Bureau of Supportive Housing, so we are not new to social determinants of health work. We have simply an expanded focus. Our primary responsibility is to integrate health and human services across New York State. At the close of today's webinar, we will have addressed the following items: social determinants of health and CBO requirements in the VBP roadmap and where we are now, community-based organization engagement in VBP myths and facts, community-based VBP contractors, exactly what are they looking for, how do CBOs fit into VBP equation, building your value, CBO contracting options, and keeping key contracting terms. At this time, I will turn it over to Martina Ahadzi, who will speak about the VBP requirements according to the roadmap.
Thank you, Denard. So this is actually just going to be a quick review of some of the roadmap requirements that addresses social determinants of health and also the inclusion of community-based organizations in VBP Level 2 and 3 arrangements. So the first requirement is that all contractors in Level 2 and 3 arrangements will identify and implement at least one social determinant of health intervention. And so this is actually on page 41 of the roadmap. So while the state requires all MCOs and VBP contractors to have at least one SDH intervention in their arrangement, it doesn't prescribe what the intervention should be or needs to be. So contractors and plans and CBOs that are working in conjunction in these arrangements can select interventions that best fit their needs and their goals. The only request is that the intervention is aligned with at least one of the 5 social determinants of health domains. And we have those domains listed here as education, social, family and community context, health and healthcare, neighborhood and environment, and economic stability. Later in the presentation, we'll talk more about these domains and what is encompassed in each one of them. The next requirement is the inclusion of community-based organizations in Level 2 and 3 arrangements, and that is that MCOs and contractors must contract with at least one Tier 1 CBO in their arrangements. Although this is a requirement, it doesn't preclude Tier 2 and 3 CBOs from participating, and in fact, the state is introducing language to include in the roadmap that speaks directly to this. And VBP contractors and MCOs are also encouraged to include more CBOs because we recognize the magnitude of the service that you provide to those individuals that are in the community with poor health. So we really encourage them to use more than one CBO. So we talked about the tier designation. So this slide kind of gives a definition of Tier 1, 2, and 3 CBO. And I'm just going to read off the slide. And here, a Tier 1 CBO is a not-for-profit, not Medicaid billing, community-based social and human service organization. Example of that will be your housing providers, social service providers, religious organization, and food banks. Tier 2 CBO is a not-for-profit, Medicaid billing, non-clinical service providers, and that will be your transportation provider, your care coordination agencies. And Tier 3 CBOs are considered nonprofit, Medicaid billing, clinical and clinical support service providers, and this includes all the programs that are licensed by the state. And now I'm going to pass it over to Ryan Ash, who is the Director of Medicaid Payment Reform, to kind of give us an update on where the state is towards the VBP goal.
Thank you, Martina, and thanks, folks, for joining. I think this is probably one of the most exciting but also more important topics with regard to value-based payment and the transition to value-based payment. If for no other reason, because of the tremendous opportunity that exists with regard to the role of CBOs and the social determinant of health interventions that can really get to the core or the root causes of poor health among individuals, but also really supporting the goals of both providers, payers, and the state to really improve care, and in doing so, deliver care in the most efficient manner as possible. So as Martina said, I'm going to just kind of walk through generally where we are in our transition to value-based payment for Medicaid, then talk through within that transition sort of how the transition looks regionally, how we're comparing against our overall goals, and some highlights with regard to social determinant of health interventions. So on slide 10, as everyone knows, we're about halfway through 2018, and just recently we surpassed the first value-based payment milestone as outlined in the VBP roadmap. That was to transition at least 10% of managed care expenditure to a level 1 or higher value-based payment arrangement. We've met that milestone, and I'll get into that a little bit on the next slide, but still on slide 10, I just want to emphasize that what's important is really where we're going, recognizing that we've met our April 1 milestone, but where we're going is April 1, 2019 to transition at least 50% to level 1, but then I emphasize the 15% of total payments to be contracted in level 2 by April of next year, and then more important, looking forward to April 2020, transitioning at least 80 to 90% in level 1, but again, I emphasize the 30% that is to be captured in level 2. So I keep saying emphasize because as we move forward to April 2020 and beyond, obviously there are financial adjustments and a lot of other activities underway to support payers and providers to move into VBP, and so one of those requirements for level 2 and 3 arrangements is to include community-based organizations, Tier 1 organizations, and certainly to also include, and there shouldn't be any confusion, to include Tier 2 and 3 organizations as well, although it's not necessarily a requirement, but it's something we certainly emphasize to make the provider networks as strong as they can be and truly span the complete spectrum of care of an individual. The other piece, of course, is social determinant of health interventions, which are a requirement in 2 and 3, level 2 and 3 contracts. So just in summary, obviously, as we move to April 2020, the role of CBOs, the inclusion of social determinant of health interventions becomes more and more important. Moving forward to slide 11, This is a general snapshot of what we've recently reported to CMS. As of December 31st, 2017, we've transitioned 34% of MCO expenditure to a level 1 or higher value-based payment contract. And then some of the other levels are outlined here, 21% for level 2 and 2% in level 3. So this is as of December 2017. We're in the process of reviewing the expenditure in value-based payment as of April 1, 2018, and we anticipate that, of course, the 34% number will increase once we finalize those numbers. The pie chart there simply reflects those numbers as well. So moving forward to slide 12, this is a overview of value-based payment contracts by region, and this is a percentage of the actual contracts that are in value-based payment by each region. It's not a percentage of dollars. That's why if you're looking at it and it doesn't match the previous slide, that's because this is a percentage of contracts, not actual dollars. So you can see throughout the state where contracts are being implemented, which is in virtually every region, and then where obviously there's more value-based payment contracts occurring. And then on the right there, it shows progress by level. So I think, you know, if there are PPSs that are on the line and you're looking at this related to your region, this gives an indication of how VBP is moving forward. And certainly if there's follow-up, well, from anyone, but PPSs with regard to this slide, I'd be happy to speak with you about transitioning more to value-based payment. So moving forward to slide 13, we thought it's important just to highlight that, you know, we talk so much about the value-based payment roadmap and moving to value-based payment, and there's just considerable effort underway from all stakeholders, from providers, payers, CBOs, associations, everybody, advocacy groups, and also the state. And so you know, the point that we really want to make here is that there really is tangible examples of value-based payment occurring in the state. These contracts, of course, are coming into the state, and then we review them based on the tiered review that's outlined in the roadmap. But for those level 2 and 3 arrangements that come in, the Bureau of Social Determinants of Health, as many of you are engaged with, works hard to review from the SDH and CBO perspective how both of those requirements are included in the contracts. And so sometimes in all of that, what gets lost are the real examples of what's happening. And so I just, you know, this is very high level, but slide 13 captures some of what's occurring, not all of what's occurring, but some of it. And I think it's important to highlight some of these examples, peer-to-peer counseling to encourage engagement, so access to care, integration with 211 services, the idea of warm handoffs to service providers, home-based coaching. So all of these different interventions, there's housing interventions certainly that are occurring. So, you know, again, these are examples of what's coming in. You know, certainly, again, if folks are excited to share what they're doing, I'm certainly always open to hearing about it and love to capture these ideas. So please reach out, and there's a email address at the end here that folks can utilize to reach out. At the very end, I just wanted to recognize that, again, the Bureau and the rest of the department has done some work to get underway a community-based organization directory that is put online and that serves or is intended to capture community-based organizations that are throughout the state that can support value-based payment contracts. And that is a directory that's online, and we've heard a few examples, but one I just wanted to identify here of a provider payer partnership that was moving to level 2 and 3 that was having a little bit of difficulty finding an appropriate CBO to engage with and partner with, and so through accessing the directory, we're able to find a partner, engage with them, and actually have now pulled them into the contract, and that CBO is now a key partner in that level 2 arrangement. So please, as the Bureau reaches out and we have those opportunities to send in your information to build out that directory, please, if you would, engage and send your information in. I think this is the first step in how we can really build out an infrastructure for CBOs to engage in and be part of what really is the future of healthcare delivery. So I think there's potential to build that piece out farther. Just going forward to slide 14, in the spirit of tangible examples, I just wanted to end this piece of the presentation with one highlight of a health system in the Bronx that invested in housing to reduce avoidable hospital visits. There's an article that you can certainly research online, and what they've said is that through this intervention, they've realized I believe at a minimum 300% return on investment. So, you know, I started this section of the presentation by talking about how, as we move to 2020, community-based organizations, social determinant of health interventions become more and more important. This is a prime example of where social determinant of health intervention identifies the true root cause of challenges and barriers or poor health among a population, and then implements that intervention in a way to really target what those barriers may be. And I think, you know, when you just take a step back and you talk to the population that you're serving, and you realize that there are reasons why folks, you know, have certain outcomes that they have, and they may be simply access to care or stable housing or food security or employment. And if we can just address those, we really improve the quality of life, but we do it in a manner that's quite efficient, and in this case, a minimum ROI of 300%. And there were stats in the article. Again, you can look these up, but I thought they were interesting just to pull out that physicians were referring to transportation being a barrier, food security, affordable housing, or stable housing. So I think this was a great example. I think the work that CBOs can do and are doing and have been doing within the spirit of healthcare delivery and certainly payment reform is phenomenal. I think there's tremendous opportunity as we move forward. There's opportunity, I think, in the way we invest in social determinants of health, whether it's through traditional means, whether that's your MCO partner or other means, but I think we also have to challenge ourselves to think outside of the box a little bit and explore what other opportunities are out there to help us invest in social determinants of health in a way where we can continue that investment and create these models of investment and return in ways where it's sort of a revolving model, so a revolving and sustainable model. So I'll end there. I could go on because I think, like I said, it's really exciting. I think it's a great topic. But at this point, I'll turn it over to Martina.
Okay. All right. Thank you, Ryan. So we'll keep going on this, and this next couple of slides sort of talks about facts and myths that we've heard through our travel throughout the state and engaging with community-based organizations with different tiers. And so the next few slides will sort of try to address some of those very common questions that we got. So the first is we wanted to just make this clear that VBP is different than grant funding because it allows for flexibility and shared savings. And so, and this is true because unlike grant funding, the funding through value-based payment does not risk expiring or running out. So you don't have a set number of, well, you need to be able to use this by this end date. So you have that available to you. Another fact is that it's not just one bucket of funding that is open to all CBOs, right? So you're not just applying for one specific amount. You have the flexibility to get involved in a number of value-based payment arrangements in whatever level that sort of meets your organization's needs. The other is that CBOs have the flexibility to be innovative in the types of services that you provide. Grant funding sometimes can be very prescriptive, so you can't do this, you need to do this in the patient's home, or they have to come to you. VBP sort of casts all of that out and gives you that ability to be innovative in some of the ways that you interact with your patients or your clients. And I wanted to add to the last one that there's also the ability to share in some of the savings that is generated through your intervention. So as payers in level 2 and 3, as they generate savings because of the intervention that you've implemented, you have the option to also negotiate to receive some of those shared savings. The third fact is that Tier 2 and 3 CBOs may implement an SDH intervention to satisfy level 2 and 3 arrangement requirement. And I think we talked about this before, but while level 2 and 3 arrangements have a requirement to include one Tier 1 CBO, the roadmap is pretty open to the fact that they can include as many CBOs and certainly CBOs in Tier 2 and 3. And so then this is a way for them to maybe perhaps expand the interventions that they're implementing to reach a much wider region or a much wider member population. Tier 2 or 3 CBOs could also partner with the Tier 1 to implement the selected SDH intervention. And also a Tier 2 or 3 CBO could be like the logical partner for a lead VBP contractor because the services that they provide aligns neatly with their goals and also with the type of arrangements that they're in. The next statement is that CBOs must take on risk to be part of VBP level 2 and 3 arrangements. Because VBP level 2 and 3 arrangements have a risk component to it, we want to make sure that CBOs CBOs are aware that they don't have to take on any part of that risk if they choose not to. So the level 2 and 3 risk is actually between the MCO, who's the payer, and maybe the VBP contractor, who's the provider. So as a CBO, if you're contracted to be a part of that arrangement, you're not taking part. You're not taking on any part of that risk because you can continue and contract based on and get paid based on the payment for the services that you provide. And if you, as you work on your intervention and realize savings, you feel confident and comfortable enough to move up or scale up your intervention, you can decide to either go into an upside only or an upside and downside risk if the interventions that you implement are successful. CBOs cannot be contractors to support more than one VBP arrangement. And that is a myth. That is not true. The roadmap certainly does ask contractors to to contract with at least one, but they can contract with as many CBOs as possible. And we again want them to do that because we acknowledge, or the state sort of acknowledges, the crucial work that CBOs are doing in the community, and the need that they're filling in helping those members with poor health get access to, whether it's fresh food or transportation, and get reconnected to their healthcare providers. So if a CBO is big enough to take on a larger geographical area, I think that's something that they can consider doing. And they can, again, we'll go through some examples later in the slide that talks about some of the contracting strategies that involve a CBO that is contracted to provide assistance to multiple VBP arrangements. And the next one is that nonprofit, non-Medicaid billing, community-based social and human service organizations may lose their Tier 1 status if they engage in value-based payment arrangement. And this is a big myth. A Tier 1, if they engage in value-based payment and not providing Medicaid billing service, they're contracted with the MCO or a VBP contractor to provide not Medicaid billing services. So they're not going to lose their status, or they're not going to become a Medicaid billing entity and losing their Tier 1 status. And if a part of your intervention requires a service that is Medicaid billable, you can potentially contract with either a Tier 2 or 3 to do that part of the work, but a Tier 1 who is providing non-Medicaid billing services through a contract with an MCO or a VBP contractor maintains their Tier 1 status because they're not providing Medicaid billing services. And so I am now going to pass this over to Emily, who's going to go over how CBOs can get involved.
Great, thank you. So just a reminder, because there's so many people on this webinar, we are going to do question and answers at the end. Just make sure you type your question in the Q&A box, not the chat box, and we'll make sure we try to get to as many of those as possible at the end. If we don't get to your question, we'll post it on our website under a Q&A document. So how to get involved? I'm sorry, what VBP contractors are looking for. So community-based organizations, they have a strong relationship with their local community and understand the root causes of poor health among their population. So as a community-based organization, you have connections to other CBOs that perform similar or different work that can be connected to what you perform. So by having those connections, a VBP contractor would be able to contract with one community-based organization that has multiple resources to refer social determinant of health issues to other resources in the community, just making a more robust social determinant of health intervention. And they look for a partnership that provides value and aligns with their goals and objectives. So, you know, if you already serve, and I'm assuming most of the community-based organizations that I talk to say that they already are serving a large portion of Medicaid membership. So if you can assign and say, well, you know, 80% of the people we already serve are Medicaid members in, you know, the Bronx. You're showing that you're aligning with their goals and objectives because you're already serving their membership, and it's something that is needed in your geographical area. An intervention that can make a measurable impact on their population. I kind of covered that in my last bullet. CBOs that have subcontractors to other CBOs and can coordinate social services for them. Like I said, having a good network and being able to refer out different social determinant of health issues for Medicaid membership. An intervention that's flexible and can be scaled up as savings are recognized. So these projects might start small with a smaller group, And then as savings are recognized, there's able to invest more into this social determinant of health intervention. So having something that's being able to scale up to multiple participants is important. And how to get involved. I can't stress enough understanding your community needs. Your community-based organizations are the boots on the ground, so you guys really have an idea of the issues in your area and how to address them. Know your community partners, be in touch with your performing provider systems, know your managed care organizations, leverage relationships that you might already have through other contracts or relationships in other community-based organizations. Understanding, VBP level 2 and 3 arrangements. Plans are moving into level 2 and 3 arrangements, so it's not like there's not a stop date of, oh, you missed the boat. It's like these plans are slowly moving into level 2 and 3, so there's plenty of opportunity to get involved in these relationships. And so it's important to understand what level 2 and 3 mean, and we do have our VBP University, which kind of gives the 101 on VBP and level 2 and 3 relationships and what different arrangements are. And use data to determine the social determinant of health intervention needed. I'll get to more of that in a minute. And leverage existing resources. There's the CBO planning grants and CBO consortiums and hubs, which are great resources for community-based organizations that are looking to get involved in VBP. And I'll talk more about developing your value proposition, which is a really important step. So in building your value proposition, it's explaining to a plan or VBP contractor what your organization does. So you can't assume that, maybe you serve over 1,000 people a year, but a VBP contractor is not going to know that information. They're going to know who their membership is, what their issues are based on data, but you're really the resource of saying, hey, this is what my community-based organization does, this is how we do it, and this is who we provide it to. So you can't assume that they know information. So developing a value proposition is a way to, flag your organization as a good community partner and someone who is, already serving that membership and can be a useful resource to develop better health outcomes and cut Medicaid costs. So key questions to answer when developing a proposition are, what does your organization provide? Who are your community partners? How much does it cost to do what you do? What is the community need, and how does that overlap with the managed care organization's membership? And how does service and geographic reach provide value in the arrangement and Medicaid population? So the key considerations, you really want to make a concise and clear value proposition. Like I mentioned, the managed care organizations, they know what negative health outcomes their population is dealing with, but as a community-based organization, you're going to know what services, social services, are needed to curb those bad health outcomes. So you're already serving many of the members. It's important to demonstrate who, being, the MCO VBP contractors membership, and what the results are. So, people that you served in the past year, did they have lower ED admissions, lower inpatient? Was there higher medication adherence? Important factors like that really demonstrate your value, and use data to demonstrate that. You should also describe why your organization is uniquely positioned to address this need. What's unique about your organization, and what innovative model do you have? Like, how do you do your outreach? So if a managed care organization says, here's my top 5% high utilizers, what could you do with that information? Know how much it costs to provide your services. So when you apply for a grant contract, you know how much your administrative overhead is, what your staffing cost is, how much it costs to set up for a new program. This is information you want to include on your value proposition, and so that you know how much it costs to serve, each participant, but also run a successful intervention. And then lastly, how will you track and measure the overall outcomes? So what metrics are important to the stakeholder? you know, this is something, you know, you might want to discuss a little bit with partners, but, you know, like I said, ED admissions, Medicaid costs overall, you know, what measurable outcomes will you have in your contract? And I would identify and communicate the process for, you know, tracking and reporting those metrics. And overall, these are key things that will determine the value to the stakeholder and really describe what your organization does and how it fits into VBP. So there's some contracting strategies, and the roadmap really leaves this flexible, and it allows for many different scenarios, but I'll just go over some of the key scenarios that we've seen and, you know, have been successful. So the first is a community-based organization can contract directly with a managed care organization and then support the efforts of the VBP contractor. The second scenario is an MCO could contract directly with a community-based organization, and then that community-based organization supports multiple VBP contractors. A VBP contractor can also contract directly with a community-based organization. So instead of the MCO directly contracting with a community-based organization, it's the VBP contractor, and then the community-based organization supports that VBP contractor. And lastly, I wanted to add this because I think this is a very strong model, you know, we stress a lot grouping together as a community-based organizations and either in a consortium or hub and being able to have subcontracts. So in this example, a managed care organization contracts directly with a Tier 2 or 3 CBO who then subcontracts with a Tier 1 CBO. And this could look the reverse way of the Tier 1 CBO contract subcontracting with a Tier 2 or 3 CBO. And there's really no limit on how many CBOs are involved in these subcontracts. You can have an entire network of CBOs that really provide a robust social determinant of health intervention for membership. There's no restriction on these subcontracts. And we have heard from plans that they are interested in, you know, having one CBO that they're able to go to with maybe multiple social determinant of health issues that need to be addressed for a member, and that CBO being able to refer out those needs. So this is a very strong model, and the CBOs would be able to provide support to the entire VBP contractor relationship. So we kind of went over this in the myths, but CBO contracts are not required to include risk. Contracts can be structured as a payment for services rendered, so you're serving you served 5 people, you get paid for those 5 people. Upside only, there's no downside risk. If savings are achieved, the CBO can receive a portion of those shared savings. If losses are incurred, CBOs would not take on any losses. Upside and downside risk would be a risk-sharing contract. You know, if savings are achieved, the CBO would receive a portion of those savings. If losses are incurred, CBOs would take on some degree of loss. The roadmap doesn't say how these contracts have to look. Again, it's between the community-based organization and the VBP contractor or managed care organization. The roadmap does say, however, that community-based organizations may be held to performance measure standards by the party they're contracting with. So some key contracting terms that are important is the contract term. So what's the effective date? When does it end? Is there a period, or will it automatically renew after an initial period? It's really important to, you know, have the terms in there, as well as the contracting parties. The scope of the project, describe what your project implementation is, what service will be provided by the community-based organization, how many people will the intervention target. And if that's not known, you can, you know, approximately X amount of people will be served by the end of the year. All members, and I guess it's also important to know, are all members in the arrangement being targeted, or is it members that meet a specific requirement? will the MCO or VBP contractor identify targeted members and refer members as needed? So will they say, here's our top 5%, this is who we want to target for this project? And how will you evaluate and measure success? It's also important to include the geographical area that the intervention will cover, what's expected for the community-based organization to cover geographically. Is it, 1 county, 2 counties? Is it, multiple areas? That should all be laid out in the contract, as well as the payment method. How will your organization get paid? Will it be a lump sum? Will it be monthly or quarterly reimbursement? Are payments tied to measures and outcomes? For example, number of referrals made or people served, contact hours. Like I said, all this isn't laid out in the VBP's roadmap. It's really up to the contracting parties, but these are really important points to have in the contract. And lastly, the data collection. How often are reports due? And what data points will be collected? What's important to the managed care organization or VBP contractor to collect? So that's for contracting options. We are going to be doing a series of these webinars. We want to be helpful to community-based organizations, and so we're really interested in what's helpful to you. What do you want to hear about? So we have this SurveyMonkey, and this will be emailed to you after the webinar, just because we want to hear back about future topics that would be helpful. So we're going to start the Q&A. So hopefully you've typed in the Q&A box, and we'll answer as many questions as possible. This is our contact information and our new website. And just give me 1 second to pull up the Q&A box. So you might see a big gray box, and I'm sorry about that. These slides will be posted. Oh, this is for typing. Okay. Yes, the slides will be posted on our website, which is on the link here, as well as it'll go out in an email. We're just going to hold the phone for 1 minute while we pull up the Q&A. Okay, so the first question is to clarify, can a Tier 1 CBO, no Medicaid billing number, enter directly into a VBP contract with a managed care organization?
So a Tier 1 CBO can certainly enter into a contract arrangement with an MCO, managed care organization, directly, and in doing so, that Tier 1 CBO would support value-based payment arrangements that the managed care organization has implemented between themselves and a participating provider. So if it's a standalone value-based payment arrangement, a Tier 1 CBO wouldn't be able to engage in an MCO for a single value-based payment arrangement between themselves and the payer because, well, for a few reasons, but one of which is that the Tier 1 CBO wouldn't have an attributed population, and the MCO, therefore, wouldn't know the population that's being covered by that CBO. But on the flip side, if a MCO has a value-based payment arrangement with a provider, a CBO could contract with the provider or they could contract with the MCO for that VBP arrangement.
Okay. Is there a list of level 1, 2, and 3 providers by county available? There isn't. We do have, because that level is changing and, providers are starting to move into those level 2 and 3s, we really recommend reaching out to those community resources like your performing provider system or to the managed care organization or VBP contractors directly, because if you do that, even if they're in level 1, they'll be starting to think about their social determinant of health activity as they move into level 2 and 3. So I wouldn't not reach out to someone because they're not in 2 and 3. This is a question about the contracting structure slides. If a CBO gets paid by a managed care organization for services rendered and supports priority. You have to scroll over to the supports other VBP contractors. Does that count as participation in a VBP contract, and does a CBO get a share of savings? So if a managed care, yes, so if you're in a contract for payment services rendered, it is participating in a VBP contract, absolutely. It's just the structure of the contract. And it would be up to the community-based organization and the VBP contractor to determine the shared savings, if there would be in this contract, or if they would want to, maybe start small and then work up to a shared savings agreement. It's really up in between the contractors. Next question.
So our next question that we have is, what is your advice to CBOs that have reached out to MCOs and tried to begin these conversations, but the MCOs are not open to contracting at this time?
So I think it's a good question. I think it pertains to really many stakeholders that we hear from, but what I would say is to continue engaging that MCO as a potential partner in a value-based payment arrangement, but then also to look outside of just the MCO as a partner and engage and reach out to other providers that may be within the geographic location that you serve. I would start with larger hospital systems, healthcare systems, larger primary care provider groups, IPAs, ACOs. Those are the groups of providers that are, at this point engaged in or about to be engaged in value-based payment. And then certainly look at the smaller, or I'll say independent primary care provider groups that may have typically smaller volume. That's a category of providers that are right now engaging in and communicating with payers to move into value-based payment. And then I would also look at other community-based organizations. So don't limit yourself to just MCOs and providers, but other community-based organizations that may have or may be negotiating or entering into value-based payment arrangements, and discuss with them how you can further support the work that's being done, whether it's by that CBO or the provider and payer that they're supporting. So really look beyond the MCO, look at provider groups. In fact, if you go to the VBP resource library, there is a document, I believe it's within the boot camp section, that outlines payers and larger provider systems per each region. And so the idea there was that that would be a stepping stone, if you will, for stakeholders to engage each other by being able to identify some of the larger groups that are moving into, if not already into, VBP.
Thank you, Ryan. Next question. In regards to building out the service directory, is there a way to make the CBO survey more visible at the DOH website? The current location is buried in a barrier to accessing and completion.
Yeah, that's a great point. We actually just released our Social Determinants of Health Community-Based Organization website. It just became live last week, and so we're going to have that be a central resource for all social determinants of health and community-based organization information and resources, links, including our survey, so that it does have a more prominent view. And you can reach our website by just Googling Social Determinants of Health and Community-Based Organizations, and that's probably the easiest way to get to it, but we will also send it out an email to all participants along with our survey link for future webinar series.
Thank you, Emily. The next question, if an Agency X operates multiple programs that can be considered Tier 1 and Tier 3, and Agency X enters into a VBP contract, is it adequate to include the Tier 1 program, or does the agency have to include an outside Tier 1 CBO in a VBP contract?
So if your organization is both Tier 1 and Tier 3, being that you have a non-Medicaid billing component and a Medicaid billing component, if those two components share a tax ID, then you would be considered the Tier 3. So you would have to have a secondary VBP contract with the Tier 1. It's determined by the tax ID again, so just because one portion of your organization doesn't bill Medicaid, it would still be considered a Tier 3 or 2 based on the sharing of that tax ID. So you would have to have a Tier 1 configured into the contract somewhere.
Thank you, Em. If a home delivery meal CBO contracts with an MLTC, does that make them a Level 2 CBO?
For home delivered meals, so if the CBO is directly billing Medicaid, then they would be considered a Level 2 CBO. But if they're not billing Medicaid, then no, they would not. It would not change their level as a CBO. It's all on if the individual community-based organization is doing the Medicaid billing. With MLTC, it is a little bit different because MLTCs can bill for meals, unlike managed care organizations through Medicaid. But it really depends on the individual community-based organization.
Thank you. The next question, how, as a CBO, do we measure our outcomes when we do not have the technology to report it anywhere?
So that's a great question, and I think it's about, you know, being able to build your infrastructure. So you have an idea of how many people you serve as an organization. And if you know what managed care organizations are your area and who's on Medicaid, you could say, we served 100 people. 90 of those people were on Medicaid. And you know what your services do. So when you're applying for a grant, for example, you're telling the state or whoever you're applying for the grant for about what your organization's outcomes are. And I think that's all we're asking for when we talk about a value proposition, is to be able to say, you know, we served these 90 people and they all had reduced emergency department visitation. You know, you might not have advanced Medicaid data, but the plans are able to see into their membership. So I think when we say, you know, use data to demonstrate your value, what we're saying is who you're serving and what the outcomes of you serving those people are.
Thank you, Em. In your suggested models, the administrative indirect costs associated with multiple contracts increase for the entities contracting with many CBOs. Will the costs be reimbursed in their rate with the MCOs or PPSs, or do they have to eat those administrative costs?
So I think in the context of value-based payment, just in general with the model, there's been investment both, if you will, on DSRIP and within the transition to VBP. So what I mean by that is, obviously with DSRIP, there's investment being made in a number of areas, but probably the most recognized is with investment to the PBS. If you're just kind of thinking about VBP specifically, again, there's investment being made, whether it's technical assistance or if we talk, you know, financial assistance or support, that would be in the that would be assistance of stimulus dollars that we've made available to managed care organizations that are transitioning to value-based payment. We've also implemented the value-based payment pilot program, again, where additional assistance was made available to parties entering into value-based payment contracts. And then beyond that, certainly as VBP is underway, there's additional adjustments that the state will make to managed care organizations that take into account quality and efficiency. So that would constitute another investment or adjustment, if you will, based on quality and efficiency. So there are a number of areas where investment is being made, like I said, whether it's technical assistance in the form of boot camps, VBP University, general outreach, the work that, for example, the Bureau does specifically with providers and CBOs, but then, like I said, financial assistance, whether that's through DSRIP, PPS payments, stimulus dollars for VBP, pilot program, VBP adjustments for quality and efficiency, et cetera. But what I'll say, I'll also end with, you know, that's a great question because it gets to the underlying point really of social determinants of health and the role of CBOs. If you kind of look at the population you serve, you assess what the total cost of care for that population is, and you identify, again, those root causes of poor health. You identify interventions that can address them and implement them. In many ways, you may realize a return on that investment, and in many cases that can become a reoccurring or sustainable source to continue that investment, whether it's in housing, food security, or employment, et cetera.
Thank you, Ryan. Next question. Most CBOs do not have access to health outcomes and cost data. which makes it difficult for them to make the linkage between the intervention and how the impact costs the health, how the impacts cost, how much the impacts cost, Mr. was supposed to say, and health outcomes. How can DOH help resolve this issue?
So a couple resources out there for data. The first is on our new website, the Social Determinants of Health Community-Based Organization website. We do have a list of data sources that the state has, as well as Census Bureau and other helpful data when you're trying to figure out, you know, who your impact is touching or what the need is for your impact. So we have that on our new website. You also have regional population health improvement programs, also known as FIPS, in your area. They have a lot of data around social determinants of health that can help with some of those needs. Cost data, like I mentioned before, you know, there might be averages out there on ED costs or inpatient that could be used, but the plans know, you know, who in their membership is high need and what those costs are. So I think it's really demonstrating, you know, your services outcomes as in, you know, the reduction of costly interventions, health interventions. So I think just keep that in mind when you're writing your value proposition. You don't have to go into, you know, claims data for X amount of participants, but it's more of what the results were from your intervention.
Thank you, Em. Next question. Is the value proposition component for CBOs mandatory or merely suggested?
So it is a suggestion. I think it helps, though, you know, really showcase what your community-based organization can do. You know, you don't submit a grant application with your community-based organization's, you know, tell us about you section not filled out, because it's really important to know as an organization who you're serving and how you're doing it, and I think you can't assume that a managed care organization or VPP contractor will know that information. So I think a value proposition is a concise, clear way to show what your organization provides and how that aligns with VBP. If you already have maybe relationships with providers and managed care organizations, maybe that's not necessary, but I think it is a way to demonstrate what you're already doing in the community.
Thank you. Next question. Will there be a central list of MCOs and VPP contractors that are actively searching for CBO partners?
There is not an active list. You can, on our new website, there's a link to the managed care organizations and VPP contractors, so you can click on that and see who's in your area. And like I said, there's different arrangements in different stages of moving into level 2 and 3. I don't think it hurts to network with all of them, because even if someone is in a level 2 and 3, they could be doing other social determinant of health interventions, or it could coincide with an intervention they already have. So I really don't think it hurts to reach out to all partners.
And just to add to that too, I think your PPSs are also a great resource and a great place to start, just to find out what MCOs are mainly in your region, and also some of the VBP contractors that are located in your in the geography that you're providing services at. So that is also available to you, as well as the CBO planning grants and consortiums too. So they're all available as resources to try to get involved in value-based payment.
Thank you. Next question. Can an MCO partner with 2 or more Tier 1 CBOs?
Absolutely.
Absolutely. The more the merrier. There's a slide that we have on that talks about, you know, CBOs being involved in VBP. And yes, the MCOs are encouraged and contractors are encouraged to include more than one CBO because we know that if we're going to curb the healthcare, right, if we're going to solve some of those root causes of poor health, we need CBOs to be involved. and having more than one, having 5, 10 kind of is the way to go, and actually that's what we're encouraging and working towards.
Thank you. Next question. Are there any networking events that you know of that aim to bring together all parties, MCOs, CBOs, et cetera, to assist in VBP growth?
So your performing provider system, they have different networking events or trainings. So I think your performing provider system in your area would be a great resource for those type of events.
Yeah.
And I'll add to that as well. One of the functions that the Bureau is actually planning to engage in is doing regional collaboratives of the sort. And I think that part of the function of those is not only to offer some type of learning opportunity, but also to facilitate these interactions. One of the things that we've learned traveling around the state is that there are some cultural differences between the managed care organizations and the community-based organizations, as well as the VBP contractors. And we understand that it's necessary to get individuals in a room kind of sitting at a table to understand that our ultimate goals are all the same. We want the best outcomes for the people for the clients that we're serving. And so we do plan on facilitating those, but as Emily did mention, the PPSs are doing this type of work, as well as the community grant awardees are doing this type of work as well. Next question. Will the state be collecting any CBO data?
So the state, we won't be collecting any of the data from these VBP arrangements directly. The managed care organization will be, and then they report to the state. So we won't be directly collecting the data, but the managed care organization will be reporting out on these social determinant of health activities. And there's been a couple questions on the website. We will email that out after, as well as it'll be posted with the slides on. So we'll make sure that we get everybody that email address.
And also just one quick comment on the CBO directory. I think we sent out a survey at the beginning of this year trying to gauge kind of VBP engagement or involvement among community-based organizations. The responses to that survey is what kind of is what we put together as the CBO directory. So if you didn't get a chance to complete that survey, maybe what we can do is send that announcement back to this group, so you can go on SurveyMonkey to fill out the survey. It is still open, so we'll have that email message or survey link go out to everyone on this webinar.
Yeah, I'm just trying to share the. Okay, we do have a few more Q&As that came in from our original documents. I'm just trying to get to those. Okay. Yes, the PowerPoint will be on our website, and we'll post the link again after we're done answering the Q&A. I'm sorry we can't have both up because of how the screen is shared.
So another question came in. Offices of the agent who are part of county government are currently providing services to MLTC throughout New York and sometimes act as a contracting CBO for their MOWs, ADCs, and transportation providers. How do you view them in the CBO tiers? I'll take a stab at that, and you guys can chime in if you need to. So the way that the tiers are structured, the tiers are are not-for-profit organizations, and so if the Office of the Agent is a government entity, it would not be considered a CBO in any particular tier. That does not mean that they're excluded from participating in VBP arrangements, but for the purposes of defining the CBO levels, they would not be considered a CBO. So another question, just wanted to clarify that the collaborative meetings will include CBOs.
Absolutely, yeah. So the goal of that will be to have individuals from different healthcare entities. So we'll have MCOs, VBP contractors, CBOs, and to make this be a way or a point of entry for some of the CBOs to get to know the contractors or MCOs in their neighborhood or catchment area. So yeah, it will definitely include community-based organizations.
Okay, it appears that we're having a little bit of technical difficulty here in terms of navigating the Q&A section of the webinar. So what we're going to do is we're actually going to give individuals back 14 minutes in their day. As was mentioned earlier, we are going to post a formal Q&A document on the social determinant website. So to the extent that your question was not answered in this particular session, there will be a formal Q&A document posted. Thank you.